Now, having considered the primary survey, we want now to go on and think about the secondary survey. And this takes place when the primary survey has been completed and the patient is physiologically stable, and we've already checked for A, B, C, D and E. And the secondary survey, although it was originally developed for trauma care, is actually equally applicable to all aspects of care: medical cases, surgical patients, trauma, and indeed it applies to first aid situations. So thinking about the secondary survey, and it needs to be ample. We need to do enough, it needs to be ample. This is where this idea came from. So the ample secondary survey as a tool for history taking was first developed by the Advanced Trauma Life Support Guidelines. But then people thought, well, it would be good to put an S in front of it. So they put an S in front of it, and we'll see what that stands for. So now we talk about a sample assessment, and this is really a mechanism for history taking, but it's a good one. So S for signs and symptoms, A for allergies, M for medications, P for past medical history, L for last oral consumption, last food or drink, and E for the events leading up to the incident or the environment in which the incident took place in. So let's think about these now. So first of all, we think about signs and symptoms. And we're getting this largely from the patient, if they're able to give us that information, or from the patient's family or other people that have come in with the patient, who know the patient, because we're trying to gather this essential historical information. So this is not so much our assessment of signs and symptoms, that will come later. This is the signs and symptoms as reported to us by the patient and their significant others. And this is remarkably important, that we know the signs and symptoms from other people. So for example, a patient might come in with delirium. Now when an older patient comes in with delirium, when I'm assessing them immediately in a first aid or A&E situation, it's very hard for me to tell if this patient has dementia or has an acute reversible delirium, because that will depend on knowing the patient, it would depend on knowing their history. So what I always ask relatives, is this normal for your dad? Is this normal for your brother? Is this normal for your mum? And you get an impression of what's normal for them. So the signs and symptoms that they've had in the past. Or a patient may have long-term diabetes or asthma, and the signs and symptoms again can be reported, what they are normally like, and crucially what has changed that has brought about seeking your attention. So in other words, is this an acute on chronic condition? So for example, a patient might have chronic obstructive airways disease that they've had for the last 20 years, but then they have an acute exacerbation and the symptoms become acutely worse. And we need that essential information from the significant others that come in with the patient. SA, allergies. Before we give any drug or any treatment, every single time we ask if the patient has any allergies. This is absolutely vital, because the principle is that we must do no harm. So we must gain this information. And this could also tell us if the patient is having an acute allergic reaction, such as an anaphylaxis. Now practically this can be a bit of a problem, because a lot of patients think allergies means any reaction to a medication. And of course we know it doesn't. We know that allergies are a particular type of adverse reaction to a medication. So patients will sometimes say they're allergic to a drug if it gave them a stomach ache or it gave them a bit of diarrhea, and sometimes we need to kind of tease out what is allergy and what is side effect, because it can sometimes be important to give a patient a particular drug, and if they're not allergic to it, we like to go ahead and give the drug. But we always check for allergies, so we ask the patient any allergies, and we ask the relatives or significant others with them as well, and of course we record that information. And if patients are allergic to things, we normally write that in red on their notes somewhere to avoid the possibility of that ever being given in error, which of course is quite unthinkable. could potentially cause a systemic, potentially life-threatening reaction. SAM, medications. Of course, we need to know the medications that the patient is on. We need a full list of medications, and we need their doses of the medication. And the medications will also guide us as to what is wrong with the patient. It will also guide us as to their chronic conditions if they have any. So, for example, if they're on asthmatic medication, or if they're on diabetes medication or heart disease medication, that will indicate that that underlying condition is present. Or especially we want to know if there's been any changes in medication, because if the medication has changed, that could bring about the signs and symptoms, the clinical features, which bring about the admission. It could be an iatrogenic problem as a result of medication taking or other medical problems. So we need to know about medications, absolutely vital. And we also need to think about toxins that the patient might have been exposed to. We can include that under medications. And in the A&E situation, it's absolutely vital to know if the patient is on blood thinners. Are they on any anticoagulant medication, rivaroxaban or warfarin or heparin? So, for example, if a patient's had a head injury and they're on anticoagulants, then that makes the risk of intracranial hemorrhage so much greater. So we need to know what medication they're on, so we can account for possible side effects that the medication may start to have as a result of this acute condition or acute trauma that the patient has developed. So fundamental to know about medications. Past medical history, of course, we need to know the past medical history. And this can include things like the age of the patient, the size of the patient, the sex of the patient. All these things can have clinically significant things for us to think about. And then we want to know if there's any long-term conditions. Have they got diabetes mellitus? Have they got COPD? Have they got ischemic heart disease? Have they got a history of atrial fibrillation? Have they got a malignancy? Have they got a history of deep venous thrombosis? Have they got a psychiatric history? All of these things are essential for us to know about the past medical history. Some we get from the patient, others we get from significant others with the patient. And again, we have the possibility here of an acute on chronic condition. So someone may have diabetes but then develop acute hypoglycemia. Or they may have diabetes, but if they haven't been taking their insulin, they might develop diabetic ketoacidosis. So if we saw the clinical features of diabetic ketoacidosis, and we had a history of the patient taking insulin but reduced insulin doses lately, then that would very significantly aid our thinking and get us towards a diagnosis. And we also need to know the history of the present complaint. How has this happened recently? So we want the long-term history, and we want the more acute history, acute and chronic history of the condition. Last oral intake. When did the patient last eat, and when did they last drink? Now, obviously in trauma this is of vital importance because there could be vomiting, and especially if the level of consciousness is reduced, there could be aspiration as a result of that. If the patient's stomach is full, that gives us something extra to think about. But there again, if the patient's not eating, then that could explain part of their medical problem as well. They could be malnourished. Or if a patient's not been drinking, then that could again contribute to medical problems like dehydration. And of course, anaesthetist will certainly want to know this information prior to any possible sedation, whether it's for a medical, surgical or a traumatic problem. So we need to know when they last ate or drank. And then the events and the environment leading up to the condition. So in trauma, we certainly want to know about the mechanism of injury. What happened? Did someone see it? Because the mechanism of injury tells us an awful lot about the potential injury that the patient has sustained. So was it a high energy trauma, such as a road traffic accident or a gunshot or an explosion? Or was it a lower energy form of trauma, which again will give rise to possible other types of injury? Or was it sharp, penetrating injury? Or was it blunt injury? Because all these are associated with particular things that we need to look out for. And also thinking about, as well as the events, the environment. So was the patient in a cold environment? Had they been cold and wet, in which case they may be hypothermic, which would alter the clinical picture that we're seeing? Or have they been in an environment where they're exposed to a toxin or to chemicals? Or have they been in an environment such as a fire where they've been exposed to carbon monoxide and therefore may be suffering from thermal inhalation injuries and carbon monoxide poisoning? So all these aspects of history collecting are remarkably useful, and we need to collect these in a systematic way. SAMPLE. Now the second part of the secondary survey, the second part of the secondary survey is a head-to-toe examination. So sample is the history collecting part. The head-to-toe examination is your physical examination part. And this literally, as it said, it starts from the tip of the head and goes all the way down to the toes and everything in between. So we're assessing the head, the cranium, the facial bones, the neck, the vertebrae, the shoulders, the chest, the abdomen, the pelvis and the associated organs, the limbs, the long bones, the fingers. We are doing a full examination of the patient to get as much additional information as we can get. And this is where we look for signs and symptoms. The signs being something that we see, or we smell, or we feel, or we hear, something that we detect with our senses, and the symptoms being something that the patient complains of. So we've already got that from the relatives, now we get it first hand from the patient, and that this gives us additional vital clinical information, all part of the secondary survey. So immediately follows A, B, C, D, E. This is when the secondary survey takes place. And it allows for standard operating procedures, SOP, and standard operating procedures and communication. Now what this means is that we can do the same thing every time. We have a way of doing it, and if you get into good habits when you're young, you'll keep those habits all of your life. We have a standard way of doing it. So we take the SAMPLE and then we do the head to toe examination in a systematic way. Then we don't forget anything. And that also allows us to communicate with our colleagues clearly. SAMPLE, head to toe. We can communicate clearly because we do it the same way every time. And you might think that gets boring, but it never does, because the patient's different every time. So although we're doing it the same way, it's reassuring for us. And then sometimes if you're having a busy day, you look back and you think, oh, I wonder if I did such and such. But then if you know that you did it in your standard way, using your standard operating procedure, doing it the same way every time, then your mind can be reassured that you did do it, because you always do it, and you always do it in that order, in that way. So this rapidly gathers history, crucial to the management of a new patient. The sample gathers the history, the physical examination gives us this additional information. This is fine to do. You can examine the patient in any way you want, as long as you don't do any harm. You mustn't do any harm, so we wouldn't want to be destabilizing fractures or anything like that. And I'm sometimes rather reluctant to do full examinations, especially in the A&E department. So for example, if a patient comes in with appendicitis, I don't really want to test for rebound tenderness, because that hurts the patient, because the surgeons are going to come and test for rigidity and rebound tenderness anyway. That's guaranteed, they'll always do it. So sometimes we want to minimise the amount of times that painful procedures are carried out on an individual. But as long as we don't do any harm, collecting information is always good. The secondary survey is indicated in all trauma patients, so this is designed for trauma, but as we've said, so many medical applications as well. And the purpose of the secondary survey is to obtain a complete history, that's the sample, perform a head-to-toe physical examination, and reassess A, B, C, D, E. So part of the secondary survey is reassessing the primary survey to make sure that nothing in the primary survey has changed. If it has, we need to go back and we need to correct that first of all. So the secondary survey is carried out when the primary survey is completed, when resuscitative efforts are underway if we're in a critical situation, and when there's normalisation of vital functions. So this is always carried out, the secondary survey is always carried out on a physiologically stable patient. And it takes us more time, and we can take our time more with the secondary survey because we know that A, B, C, D, E are in place. And the secondary survey also includes a full neurological examination, including the Glasgow Coma Scale. And secondary survey, we can order required investigations. So the patient may be referred for an X-ray or for a CT scan. And certainly this is going to involve hematology and biochemical blood work, which we do on virtually every patient that comes in. So there we are. Secondary survey comes after the primary survey in two parts: sample, head to toe examination.